Okay, let's dive right into this. Welcome back to our masterclass on myocardial infarction ICD-10-CM coding. Today, in part 3, we're doing something really crucial. We are bridging that gap between the clinical pathophysiology and accurate code classification. We're literally getting right to the heart of the matter, making absolutely sure your clinical documentation perfectly aligns with your coding output. So here's our clinical to code pipeline for this explainer. We'll start big with the macro architecture of Chapter 9, dig into the actual pathophysiology of ischemia, navigate those specific I20 through I25 categories, and then finally connect real-world patient symptoms to our actual code blocks. Let's get going. All right, starting off with Section 1, our Chapter 9 architecture overview. We're essentially setting the stage here for circulatory system coding. If you open up your ICD-10-CM manual, our absolute foundation is Chapter 9, Diseases of the Circulatory System. That encompasses codes I00 through I99. Now, this is a really broad block. It houses everything from rheumatic to hypertensive diseases. But, it sets that essential structural stage for the ischemic spectrum that we're going to laser focus on today. Moving right along into Section 2, let's look at the pathophysiology of ischemia. What's actually happening inside the patient's heart. Because to code this accurately, we really need to step away from the coding book for just a second and look at the patient's anatomy. It all starts with one fundamental phrase: coronary insufficiency. This is the root cause of every ischemic disease we're about to code. Simply put, it just means the heart muscle isn't getting that vital blood flow it absolutely demands to function properly. So how does that clinical deterioration progress? Well, step 1 is the buildup of atheromatous plaque right inside the coronary arteries. Naturally, this leads directly to step 2, which is reduced myocardial blood flow. Now, when that lack of blood flow sticks around, we hit step 3, prolonged ischemia. And if that ischemia isn't reversed quickly, it triggers step 4, irreversible necrosis. And that right there is the actual infarction. Which brings us to our core clinical definition. A myocardial infarction is the irreversible myocardial cell death, specifically necrosis, due to that prolonged ischemia. Now, as coders, listen closely to that word necrosis. It's the defining clinical factor that separates a true heart attack from just an episode of severe angina. All right, on to Section 3, navigating categories I20 to I25, the ischemic heart disease spectrum. Let's bring our focus back to the manual and actually map that pathophysiology directly to our specific code categories. Now, what's really interesting about this is how elegantly the ICD-10-CM structures this disease progression. It's a true spectrum. We start at I20 with angina pectoris. Then we escalate right into the acute conditions, I21 for an acute MI, I22 for a subsequent MI, and I23 for current complications following that MI. Then I24 captures other acute ischemic conditions, and finally I25 settles into chronic ischemic heart disease. It's basically a perfect clinical timeline, just translated into alphanumeric blocks. Next up is Section 4, connecting symptoms to codes, basically translating the clinical chart. Now it's time to look at what the provider actually documents the moment a patient hits the ER doors. When you're scanning the medical record, look for this vivid clinical picture. You'll see things like sudden, crushing chest pain radiating right to the jaw or the left arm. The provider might also document shortness of breath, dizziness, nausea, or vomiting. Or say you have a patient with known heart disease. You might see a note that the pain is much worse than usual and triggered by far less activity. These are your massive red flags triggering the search for an I21 category code. But, of course, symptoms alone don't give us our highly specific alphanumeric code, right? We need the clinical workup. A 12-lead ECG differentiates between a STEMI and an NSTEMI. Cardiac enzymes, specifically troponin I, confirm the actual myocardial necrosis we talked about earlier. And then imaging tools, like an echocardiogram or coronary angiography, well, they identify the exact blocked artery. Ultimately, these diagnostic tests provide the highly specific documentation you need to assign the most accurate code. And this brilliantly illustrates how the underlying cause completely shifts our coding logic. Check out this comparison. A type 1 MI is a primary coronary event. It's spontaneous. Think of a plaque rupture directly blocking the artery. But a type 2 MI, that's secondary to an ischemic imbalance. This just means the heart needs more oxygen than it's getting, but due to something else entirely, like demand ischemia, a vasospasm, severe anemia, or hypotension. Now, this leads us to a very strict ICD-10-CM coding guideline. If the documentation describes a type 2 acute MI, even if the provider explicitly calls it a STEMI or NSTEMI, you only assign code I21A1. You absolutely do not assign a separate code like I24.8 for demand ischemia. Code I21A1 covers the whole shebang, followed by the code for the underlying cause if you know it. So the crucial point here is how we handle readmissions within 4 weeks. If a patient comes back with a subsequent type 1 MI, easy. You assign a code from category I22. But if they return with a subsequent type 2 MI, a major excludes one note kicks in. You do not assign I22. For any subsequent type 2 MI, you only assign code I21.A1. It's a tricky one, but super important. Finally, we've got to differentiate historical conditions from non-ischemic injuries. Code I25.2 for an old MI is essentially just a history code. Do not assign it if current ischemic heart disease is actively present. On the flip side, if the provider documents a non-ischemic myocardial injury, we're looking at code I5A. But remember, the guideline strictly requires you to code the underlying cause first, whether that's heart failure, sepsis, or myocarditis. And there you have it. We've journeyed all the way from the macro architecture of Chapter 9 through the progressive pathology of coronary insufficiency and necrosis, mapped out the entire I20 to I25 spectrum, and even tackled those tricky coding guidelines for type 2 MIs and subsequent events. Keep these clinical pictures and guideline nuances in your back pocket, and you're going to navigate this spectrum with total confidence. Decode Healthcare with Harshal.